Hello, and welcome to the APTA Oncology Section Student and New Professional Subcommittee's Diagnoses Downloads. Thanks for tuning in to this month's topic of skin cancer. The month of May is deemed Skin Cancer Prevention Month by the American Academy Dermatology Association, and thus we will be diving into the common forms of skin cancer, typical treatments, clinical implications, and the physical therapist's role throughout the continuum of skin cancer care. Skin cancers are the most common of all types of cancer and can be classified as either non-melanoma skin cancer or melanoma. Melanoma, the more serious form of skin cancers, has a 5-year survival rate of greater than 90% if localized, but if invasive, the 5-year survival rate can be as low as 13%. With melanoma, the primary warning sign is an asymptomatic pigmented lesion with atypical features. However, patients with moderately advanced lesions may present with bleeding, crusting, itching, or tenderness at the site of the lesion. A changing mole, the appearance of a new mole, or a mole that is different or growing requires prompt medical attention. Palpable lymph nodes may also be present in these cases. Most skin cancers are classified as non-melanoma and are slow-growing, easy to recognize, and responsive to intervention. Non-melanoma skin cancers can be further classified as basal cell or squamous cell, depending on the tissue affected. They rarely metastasize and have a very high cure rate. Squamous cell carcinoma arises from the top of the epidermis and is found on areas exposed to the sun, which includes the rim of the ear, the face, lips and mouth, and the dorsa of the hands. Squamous cell carcinomas can also occur in scar tissue, so always ask to see and examine your patient's scars from previous surgeries, especially when there has been a history of any kind of cancer, including skin cancer. These lesions appear as small red hard nodules with a smooth or warty surface. The central portion may be scaly, ulcerated, or crusted. Basal cell carcinoma involves the bottom layer of the epidermis and occurs on hair-bearing areas exposed to the sun, including the face, neck, head, ears, hands, and may appear on the trunk, especially the upper back and chest. There are a number of forms of basal cell carcinoma, including a pearly papule with a small crater in the center, a scaly red, sharply outlined plaque, or an ill-defined pale, tough scar-like tumor. There are a number of treatments that may be indicated in the case of skin cancer, including chemotherapy, radiation therapy, surgical resection, and lymphadenectomy. In regards to chemotherapy, individuals with in-transit disease or disease that has spread through the dermal and/or subdermal lymphatic pathways at least 2 centimeters from the primary lesion but have not gone past the regional nodal basin may be prescribed regional chemotherapy consisting of isolated limb perfusion and/or isolated limb infusion. Radiation therapy can be used in the treatment of skin and lip cancers and may be used in the setting of where negative margins cannot be obtained from surgery due to the size or the location of the tumor and may be used adjunctively after surgery. Superficial X-rays are primarily used for treatment of basal cell carcinoma due to their low penetrating power, resulting in the maximum dose deposition near the surface. Single fraction ablative treatments of radiation are frequently used with curative intent with several cancers, including melanoma. With squamous cell carcinoma and basal cell carcinoma, surgical resection is the most common treatment method, and surgery is appropriate for most cases. Surgical resection is actually the primary intervention with cutaneous melanoma. A wide excision with a negative margin of 2 centimeters is considered acceptable resection, and if that cannot be achieved, radiation therapy may be indicated as mentioned previously. Complete regional lymphadenectomy is the standard procedure if there is involvement of regional lymph nodes. Throughout the continuum of cancer care, from diagnosis to intervention, skin cancer can have a deleterious effect on a patient's functional status and quality of life. According to research, morbidity and mortality are reduced when cancerous lesions are found and treated early. Thus, by utilizing the ABCDE assessment screen of integument, we can take part in the early detection of skin cancer. The A represents asymmetry or uneven edges, lopsided in shape, or one half unlike the other half. B stands for border irregularity and describes irregular, scalloped, or poorly defined edges. C represents color variation, meaning black, shades of brown, red, white, or occasionally blue. D is for diameter, greater than 6 millimeters or the size of a pencil eraser. And E is for evolving, meaning the mole or skin lesion looks different from the rest or is changing in size, shape, or color. The A, B, C, D, now including E criteria, have been verified in multiple studies documenting the effectiveness and diagnostic accuracy of this screening technique. Now let's discuss the physical therapist's role throughout this process. The physical therapist is a member of the oncology rehabilitation team by assessing, screening, intervening, and of course educating these patients. From the assessment standpoint, performing a risk factor assessment for skin cancer is essential since all adults, regardless of skin tone or hair color, are at risk. However, some may be at greater risk than others. The Skin Cancer Foundation includes those at greater risk of advancing age, having personal or family history of skin cancer, particularly melanoma, having moles with any of the ABCDE features or moles that are changing in any way, complexion that is fair or light with green, blue, or gray eyes, skin that sunburns easily or skin that never tans, history of painful sunburns with blistering during childhood or adolescent years, use of tanning beds or lamps, short, intense episodes of sun exposure, or being a transplant recipient. That's why it is crucial we screen integument and identify potential metastases. Early detection of a lesion may allow for complete excision with no further treatment warranted, emphasizing the importance of performing a regular and systematic integument assessment. We should also ask our patients, how long have you had this? Has it changed in the past 6 weeks to 6 months? And has your physician seen this? As physical therapists, we are well equipped to treat the impairments that often accompany oncological treatments and assist our patients in maintaining their optimal level of function throughout their cancer course. Referring when appropriate and warranted may also aid in early detection and appropriate intervention of cancerous lesions. The Skin Cancer Foundation, among other resources, has public education materials available to therapists to help identify suspicious skin lesions, as well as education materials that can be provided to patients. So what are the takeaways from this presentation? Skin cancer is the most common form of cancer occurring in humans. 1 in 5 Americans will be affected by skin cancer at some point in their lifetime. So consider implementing a regular and systematic integument assessment with the ABCDE criteria to accurately identify potentially cancerous lesions. Physical therapists can aid in the detection of lesions with the use of screening techniques, which may reduce an individual's morbidity and mortality associated with skin cancer. Physical therapists can also investigate resources to further help them identify suspicious lesions and provide education material to patients as a form of primary prevention. Resources of information gathered for this presentation are included for you here. Thank you for tuning in to this month's topic of skin cancer, provided to you by the APTA Oncology Section's Student and New Professional Subcommittee, and we hope to see you again for our next diagnosis download.